You're very welcome to the second last Geary seminar of this semester. Two housekeeping issues. One, phones to silent or off. Two, the usual please mind your guests attitude. It's likely to fly off with your lunch. I'm delighted to welcome Kate Frazer, who was successful in her application for funding under the Geary BICS visitor scheme. And Kate has used this funding to bring her speaker here today. So without further ado, I'll pass over to Kate, who will introduce our speaker.
Hi everybody, it's lovely to meet you all, and as I say, thank you very much to Darren and to Michelle Norris actually for the funding. It was fantastic to actually get that and to be able to bring Negin over here, and to the Geary Institute for supporting the visit. So I'd like really sort of as a context and then to introduce Negin just very briefly to say that I suppose in 1973 the US Supreme Court decision that the Constitution of the United States protected a right to have an abortion was a landmark decision. And then in June 2022, historic and far-reaching decision of the Supreme Court then officially reversed that Roe versus Wade, declaring that the constitutional right to abortion upheld for nearly half that century no longer existed. Since that decision, it's estimated that about 22 million women of reproductive age, about 1 in 3, find themselves living in the states when abortion is unavailable to them or they're severely restricted. And the impact of the restrictions is not felt equally, with many systemically marginalised groups facing disproportionate burdens and challenges of accessing reproductive health services due to, a lack of health insurance, underinsurance, low educational employment, and living many distances from actually good reproductive health. So we have to think about that. So today we are very fortunate to hear from Dr. Negin Fouladi, who is a member of faculty at the University of Maryland in Washington and is a visiting fellow at the UCD Geary Institute. She is the director of several master's programs in public health and public health policy at the University of Maryland. And today she will discuss the US healthcare policy and its implications for Roe versus Wade across the US, particularly its impact on women's health. And I hand over to you.
So again, thank you so much everybody for having me. This is wonderful. It's been a really great collaboration working with colleagues here at the Geary Institute. I work with Kate and the folks at the School of Nursing and Midwifery in the health system section, and I'm from the School of Public Health in College Park. And like Kate said, I wanted to bring this up because this has been a huge hot topic. I don't know if you all watch the news or not. Of course you do. It's been a huge topic in the US over the past few years, and particularly it became a hot topic during the election, although after the election with the polls, it basically we realized that it actually was not a decisive factor in the presidential nomination. But the point is that it was leading up to it. It is a very hot topic. So I want to start this actually out by giving an overview of the US healthcare system, because I don't know how familiar you are with how it's organized. It's always good to understand what the health system in the US is, because it has a lot of ramifications on how policies are implemented and their outcomes. So just a quick overview of the US healthcare system. We do not have universal care. We don't have national health care. We have a very sectioned off system. We have private financing and we have public financing. Basically, we have a private and public system. We're not universal. We don't have a single payer approach. And this is just a quick schematic to show you how the system is organized. Again, we have public financing, which finances public programs for specific populations, and we have private, which is basically health insurance companies, employer health, and that's just a quick overview of that. Again, looking at the public and private, our public system is basically financed through the federal government, and also states are in charge of certain things. The public systems that we have are Medicare, which is for elderly populations 65 and above, and also individuals that have end-stage renal disease in certain populations. Medicaid is for low-income populations, and I'm going to go over this federal poverty table in a minute with you. We have a children's health insurance program. We have the Veterans Health Administration for VAs. This is actually a single payer. This is the closest we have to universal health care in the US. It's a single payer system where all the physicians and everybody's employed by the government, but that is not the case for anywhere else. And we have Indian Health Services. We also have military healthcare for active military, it's called TRICARE, but that basically follows a private system model. Basically, they just get health insurance. Then our private system, basically, employer coverage. Majority of the people in the U.S. are covered by, they have jobs and they're employed and they get covered through their employer. That's the majority of the people. Others as well get health insurance individually. And since 2010, one of the main mechanisms of purchasing insurance individually is through the health insurance exchanges that were developed as part of the Affordable Care Act, which was our most recent, what we call health reform, which really is not truly what we think of health reform. It was really health insurance reform. That's really what it is. But it created marketplaces at the state and federal level where individuals can go in there and shop, compare plans, health insurance plans, and actually purchase. I put this up here because when we start talking about folks that are uninsured or low income and women down the line as we're going through the presentation, it's good to have an idea of what federal poverty levels are in the U.S. They change every year based on, inflation and so on and so forth. But especially when it comes to Medicaid, which is for low-income populations, and Medicaid is a federal and state joint program. So the federal government has certain stipulations, and the states implement them. So, and the states can also adjust Medicaid percentages, eligibility based on what they deem is right for their state. But in order to be eligible to have Medicaid, you have to meet a certain federal poverty level within the United States. And just to show you, for 2024, the federal poverty level standards for an individual is $15,000. This is the general federal poverty level for a family of 220, family of 431, so on and so forth. To be eligible to get Medicaid, you have to be below 138% of the federal poverty level. And that translates to not that much more than this. Can imagine if you're a family of 4 and you're making $31,000 for, I think, depending on where it is, I think maybe it's like $45,000, something like that. If you make above that, you can't get Medicaid. You're either uninsured or you have to figure out how to pay. And that's nothing. I think it's very similar in euros. 45,000 is what? How many euros? Not to imagine 2 children, 2 adults. So it's very, very challenging. I just wanted to kind of keep that in your mind. Again, talking about this Medicaid issue, because this is very important. When we did have the health reform in 2010, one of the major provisions of health reform was expanding Medicaid, meaning increasing that federal poverty level requirement, so more people that are uninsured will be able to be eligible to get insurance. Again, it was not nationally, initially it was nationally mandated. It went through courts back and forth. Some states said, we don't want to do this. It went through courts several years. So basically, to this day, 41 states adopted expanding Medicaid, increasing their federal poverty level to minimum 138. And we still have 10 states that have not. And let me tell you, the federal poverty level requirement for Texas is, I think, 20-something percent. 20% of that, $31,000. Okay, I think Mississippi, Alabama, all these 25, 15, maybe 30% of the federal poverty level. These are the people that are eligible to get Medicaid. Imagine, family of 4, 20% of 31,000, that's nothing. So if you make above that, you're not eligible to be on Medicaid. So this is actually really important, because it does impact, again, women that are low income. Yes?
The blue states, they just didn't change.
The blue states, so yes, these there are certain states that already had good eligibility, and they didn't need to expand. The ones that expanded were the ones that were very low to begin with, and then they expanded to meet that requirement. And again, but one more thing I also want to say is the ones that have not expanded, typically these states, these southern states, are the ones that have the most needy populations. They're the most low income. They have a lot of ethnic diversity, and they have chosen not to expand. So this is the current state today. All right, again, a quick landscape of where we are with the percentage of people that are covered under what today. To this day, well, at least up to 2023, we still have 8% of the population that's uninsured. I think that's around 25 million individuals that are still uninsured, that don't meet any eligibility and can't afford to get insurance. Um, the percentage of people that have any kind of a private plan overall, 65%, majority are covered by employer and other ones. Any public plan, Medicare, 18%, well, 19%, Medicaid, 19%, and the VA and Champion, which is the VA healthcare system. But again, you see, that's a huge percentage, you know, and a huge number of people still to this day. Breaking down the uninsured really quickly, percentage and number of people who were uninsured by age group, 22 and 23. Again, it's like 25, you know, 22 was 8.4, 23, 7.6. The numbers did reduce a little bit, and that was mainly due to COVID, COVID hitting, and a lot of the benefits and eligibility requirements that were modified during COVID for people to get uninsured. But again, that's still a high number. All right. Like I said earlier when we first started, abortion is a very complex and hot topic in the US. It has been, especially since 22, when Roe v. Wade got overturned. But just a quick overview of, you know, why it's important that we want to really look at this. Because abortion now is in the hand of states, and before Roe v. Wade, it was a national statute. When Roe v. Wade got overturned by the Dobbs and Jackson case, control has gone to the states, right? So it's important because not every state is going to react the same way, whether they're going to allow abortion or not, or the restrictions they have. But in general, you know, restrictions impact access to safe and legal abortions. We all know this. They lead to delayed care. They create financial barriers. They reduce the options, actually, folks have, these anti-abortion laws, and because they lead to closures of clinics and so on and so forth. They highly impact vulnerable populations, highly impact. They impact mental health. They impact maternal health. They create stigma and discrimination. And they highly impact medical decision making, and we're going to talk about this. They impact on providers and provision of care, not just the users of care, but also the folks that provide the care. That's very, very important. Okay. So Kate gave a quick overview of the history of these regulations, but I want to just, again, reiterate it here for you all. So Roe v. Wade was a 1973 case, basically, that established constitutional right to abortion nationally in the United States. Okay, that was, and the central issue for that case was Roe, that was a pseudonym for the woman. The central legal issue, again, I'm not an attorney, but the general legal issue was whether a woman has a constitutional right to choose to have an abortion, and if yes, to what extent the state can regulate or restrict that right. That was the legal case for Roe v. Wade, and the Supreme Court, I believe they ruled 7-2 in favor of this case, and the lady's name was McCorvey. That was Roe. The court held that a woman has the fundamental right to choose to have an abortion under a constitutional right to privacy, and it established the framework for evaluating state abortion laws during pregnancy. Okay, and it also divided pregnancy into trimesters. That was one of the outcomes of the law. So we've had this around since 1973. Obviously, you always have pro-life, anti-life, you know, you have all these things happening, but what happened is in 2022, on June 2022, we had a case, Dobbs versus Jackson's Women's Health Organization. This was in Mississippi, where the Supreme Court that overturned Roe v. Wade, the Dobbs decision basically gave individual authority to regulate abortion. It took it away from national and gave it to the states. So the states can choose to what level, if they're going to allow abortion or not, and not, or to what level they're going to do it. And the central legal issue here was whether the state of Mississippi, for this specific case, the state of Mississippi's state law ban on abortions after 15 weeks of pregnancy was constitutional. That was the legal reason for this case. And they said yes. So it went over to the states. So the major provisions of the state abortion laws, there are several, that came about. Gestational limits tend to be the most dominant, but in general, the provisions include physician and hospital requirements, partial birth abortions, public funding, Medicaid funds to be able to pay for abortion, coverage by private insurance, refusals by providers based on religious faith-based, and this is actually, there have been several cases of that, women being turned away from Catholic hospitals and so on and so forth, or religious-based, faith-based hospitals. Mandated counseling requirements in order to be able to get an abortion, waiting periods, and parental involvement for individuals that are minors to be able to get abortions. So these are some of the basic provisions. Now, pre and post Dobbs in 2022. This is a really nice picture to show you how quickly things turned. Okay, before the June 22 Dobbs decision, obviously, right? It was a national abortion was available nationally. There were 3 states that had some gestational limits, and that's it. June 22 was when Dobbs went into. June 24th. Look what happened. You start seeing states starting to ban. Little by little, 12 states don't have abortion access. Like literally within how many days? 12 states got rid of abortion access. 1 had gestational. By the following year, in 1 year, we have 14 states that banned abortion, and then 6 states with gestational. It's just to show how quickly these policies impact decisions at the state level, or within anywhere. Public opinion about this is always important to know. Although we have legislation, we also have the public opinion as of May 2024, and this is actually a little bit old because we just had an election. So that's, but up until the election, as of May 24 until the election, 60% of the population said abortion should be legal in all or most cases. Okay, and 36 said it should be illegal in all or most cases. This was the opinion. Okay, and again, looking at 2020, okay, compared to 2023, the number of abortions recorded, right? So in 2020, across all 50 states and the district, remember we have a district that's not part of the state, but we count it in to everything else. We had in various states here, just to see an overview, we had 73,000 in California, 55. In 1 year, we had an increase, right, of abortions estimated across 36 states and Washington, D.C. But again, this is just to show you, within a 6-month period, right, what's going on here, right, when you have all these changes. All right, we just had an election not too long ago. I don't know if you all heard, but we had a presidential election. As part of that election, we actually had, I believe it was 10 states altogether that put on the ballot, on the actual state ballot, in addition to the presidential nominee, they actually had state ballots for abortion rights. To protect abortion rights. 10 states, these were the states. And basically it was Montana, Nevada, Arizona, Colorado, Missouri, New York and Maryland, South Dakota, Florida, and Nebraska. Okay, so 7 states passed, the ones in green, okay. 3 states failed, although 2 of them met 50% approval. They didn't meet that state's percentage, which was 60% or so. Florida's one, and I think it was also, is it South Dakota or Nevada, one of them. Again, it didn't meet that threshold, the state's required threshold, although 50% or so of the population had voted to approve. So it was denied. And I do want to kind of point this out, that when we talk about abortion ballots, what goes on a ballot, there are 2 types of approaches to that. One is a legislatively referred approach, where you have measures are introduced and approved by lawmakers, legislators before they appear on the ballot, and then citizens vote on them. And you also have citizen-initiated um, um, ballots, which basically they're written by citizen groups and are placed on the ballot if they receive enough signatures. All of these states right here, let's see, 2 states, New York and Maryland, were legislatively referred. So they were already decided pre-hand and they were put on the ballot. All the other states were citizen initiated. And I think that's important to know because, again, you're talking about states that, for example, may not have had approval before. Now the citizenry is saying, okay, we want this to be there. So that's actually really important. South Dakota, Florida, and Nebraska obviously were citizen initiated and they didn't pass. Again, although they met a 50% threshold, they didn't pass. It's just a nice picture of seeing what's going on there. So the status of abortion bans in the US, and I believe this is from, it says November 6th, but I think it was more updated. So as of now, with the ballots and everything, we have 41 states that have abortion bans in effect with only limited exception. Mainly they are, basically they're not as, what's the word for it? Restrictive, let's say, okay? They're pretty much open. 13 states that have total abortion ban, okay? And you can see up here based on the color, red is complete abortion ban. 28 states that have some kind of a gestational duration limit, okay? So, orange, what is it? Orange, lesser red, I guess. I don't know what you would call that. I can't see from here. And then light blue. And then the dark blue are the states that have no gestational limit whatsoever, okay? And that includes, again, District of Columbia, DC, which is not part of a state. But these tend to be blue states anyway, very progressive and liberal states. All right, just a comparison globally. I know you all went not too long ago. Ireland went through a referendum and a change. Just to see the state of what's going on globally, we have a trend towards increasing access, right? Over the past so many years, and I have to go back and see exactly what this year, I put this together last year, so it's pretty recent. But if you can see, many countries are actually starting to become more progressive and have increased access, Ireland being on there, right? Towards basically having abortion approval. The US has gone backwards. And Nicaragua is another country, but it's just to see globally what's going on. Okay, we're not the only country that's going backwards, and you all are not the only country that has in the past few years developed more access for abortion. This is just another view of this to show globally what's going on. Again, most nations are, allow abortion. Gestational limits vary. Others, they allow abortion based on social economic grounds to preserve health, so on and so forth. And again, US, we went backwards, basically. Just a good way to kind of visually see that. Okay, this is another way of, oops. This is not supposed to be on there. Sorry, now this is moved. It's supposed to be below, but I'll tell you in a minute. It moved when it came on here. So this is actually, it's a nice way of saying, okay, when you have increased access, what happens? When you decrease access, what happens? So abortion rates decrease in countries where it's legal. Okay, so this is actually supposedly going to show you that countries that have decreased it's supposed to be this way. So countries where abortion is broadly legal, there's been a 43% decrease. Okay? Countries where abortion is restricted, there's been a 12% increase of abortions. It's the opposite, right? Sorry about that. It looked fine on my slides. It's skewed when it came here. All right, for the US, there's a lot of implications. I'm going to go into a couple of other slides about access, providers, so on and so forth. But in general, the implications are very, very important for racial disparities in our country. Because again, as I showed earlier, the individuals that are mainly uninsured and have challenges with accessing healthcare are mainly individuals that are vulnerable, that include racial, ethnic, by socioeconomic status, by race, ethnicity, and so on and so forth. We have a huge problem within the US to begin with. So this has huge implications for racial disparity in the US. So overall, in America, Black and American Indian and Alaskan Natives are more likely than other groups to live in states with abortion bans and restrictions. As I saw, usually those southern states mainly, but there are some central states as well. A lot of groups of women of color have uninsured rates. We talked about that. They're uninsured compared to their white counterparts. Women of color have more limited financial resources and transportation options. I'm going to go through some slides showing you some percentages and graphs of that. It makes it more difficult for them to go out of state to the states that do allow abortion. Because what happens when you're in a state in Texas, you have to fly somewhere else or drive somewhere else if you want to be able to get an abortion. Or basically have reproductive, access to reproductive health sometimes. And these bans and restrictions on abortions widen already the existing racial disparities we have. These things already exist. They didn't just pop up out of nowhere. But these types of policies really increase that disparity. So this is basically the challenges with it. Okay, now a few slides of showing you all a little bit more detail. So impact on access, equity, and provision of care. This is again, this actually stayed in place. I popped those in there myself too. I don't know what happened in this. So this is just a figure from Kaiser, by the way, a fantastic resource if you all don't already use this. I know in healthcare we do. Kaiser Family Foundation, the Commonwealth Fund, Robert Wood Johnson Foundation. These are really great sources for any health policy information that you want. So a lot of these are from the Kaiser family, and they're very good with updating quickly. But this is showing you basically state abortion policies by race, ethnicity among women. You can look at the breakdown, but overall, again, reiterating the fact that 25% of the population are in states that have banned abortion. That's 16.3 million women. Okay, 26%, 16, basically almost 17% of women are by race, ethnicity, and again, the breakdown here on states that have some kind of a ban, limit on abortion, and then the rest, around 50%, are in states that have broader access. But this is important right here, right? And then look at the breakdown: 28% Black, 31% Asian. I have to go on back and Asian, Indian, and Alaska Native, and then Hispanic. You see, and then the NHPI is actually Native Indian and Pacific Islander. So we do have challenges with our Native populations, really, really big problems, disparities with our Native indigenous populations as well. So this is just to kind of show you, this is what it looks like now by race, ethnicity. Coverage of women, remember we talked about access to care, Medicaid expansion, uninsured. This is to show you in general, basically health coverage of women by race, ethnicity in the US. And if you look at the total, but if you look at Hispanic, Black, Asian, the Native Americans, and the Asian and the Pacific Islander, oh my goodness, I'm mixing them all up, but you know what I'm talking about, the acronyms there. You see a huge percentage of them, are a good number of them are uninsured, or they're on Medicaid, which was for low-income individuals, right? So if you look at that, what are these policies doing, right? If you're uninsured, you can't get any care, right? If you were eligible for Medicaid, perhaps you would get some care. But what's also happened and changed is we have something that we call the Hyde Amendment in the US, okay? So the Hyde Amendment was actually 1977. It was enacted, and it bans the use of any federal funds for abortion unless it's a case of life-threatening for individuals, or rape or incest. Okay, so that's always been there. But now with the control going to states, right, states can further choose how they want to, pay for abortion. So if they want to use federal funds, they can't do that. A lot of states actually use their own personal funds because Medicaid is implemented by the state. So it's a matching dollar of federal and state, but they can choose, right? So this is a challenge as well. It's already an access issue. Okay. Remember that federal poverty level we talked about earlier? We had a nice little graph. just kind of remember those numbers, but I'm going to go back and maybe see and actually put a link. All these things have actually links to sites for you all. So if maybe I can share the PowerPoint with you guys, can actually link to different sources. But this is just looking at percentage of women. Again, we're talking about ages 18 to 14, general adult, right? Below the 200% poverty level by race, ethnicity, and state abortion policies. Okay, so if you look at race, ethnicity on top here, and the states that have banned or have limits, look at that. Hispanic, 44%, okay, of women are living in abortion banned states. 47 of Black, 22 Asian, 46 and 48 respectively with the Native American and the Asian Pacific Islander. This is huge. And we also have the ones that have gestational limits. That's a huge percentage, okay, compared to their white counterparts. Transportation, you were talking about, I kind of found these to put in there. So again, transportation is a huge access challenge for us in the United States, urban versus rural, and even sometimes urban, because somebody, an individual may not even have enough money to get a bus pass, or they're not able to go somewhere. So that's a huge challenge. So accident transportation for going to out-of-state for abortions, right? Percentage of women living in households without vehicle access by race, ethnicity. Black, 12%, Asian, 9%, again, compared to white counterparts, okay? But we also have another added issue in the United States. We have immigrants, and we have undocumented immigrants. And I'm sure you all have been hearing this in the news too. We have a huge challenge with that, trying to figure out what to do. So if you, on top of it, add immigrants, and especially undocumented, where they're already scared, where they're worried about their immigration status, they have an added challenge, right? If they need to go into a state that does provide abortion, even without abortion, non-citizens, basically undocumented immigrants, have a fear of just getting healthcare in general. So this is actually a huge problem, let alone if you have this challenge and you have to drive out of state or go into any facility, even if it's within your state, to go in a facility. This is a huge issue and a huge worry. Mortality, maternal mortality. This is a big one, obviously. But this is actually showing before Dobbs. We've always had I think US ranks, I don't know what we ranked, one of the lowest in many of the indices out there, but we already had challenges with maternal mortality by race, ethnicity. This is showing 2018 to 2021, Black, Hispanic compared to white. I will say our maternal mortality rates improved a little bit after this, and that was mainly, again, because of COVID. COVID really changed the landscape, increasing access to care for folks. But since then, I haven't really seen any updated data of kind of our post-COVID, although it's still around, but I haven't seen. But the point is that we've always had challenges with that, maternal mortality in the US. Okay, and I just have a few more slides of this, and we're going to talk about what moving forward with the new election, with the new incoming president, what's going to happen. So providers, my goodness, you need to be standing up here with me. You're a provider, US provider. A lot of complications for them too, right? In states that have banned. What are they going to do? There's so much fear. There's so much fear of legal issues and all that stuff. But this was actually, again, Kaiser Family. There's a couple of slides here I'm going to show you all. They did a survey of OB-GYNs that reporting complications of the Dobbs decision on care, maternal health, okay? So they asked them, based on your experience, do you think the Dobbs decision, the 2022 Dobbs that overturned, has it improved, worsened, or had no impact on racial, ethnic inequalities in maternal care? 70% worsened, okay? Management of pregnancy-related medical emergencies, 68% worsened. Pregnancy-related mortality, 64%. Attracting new folks to the field, new clinicians, 55% worsened. So this is a trend. This one here, just again, another survey, similar again, 50% had a patient in their practice who was unable to obtain abortions, 40% constraints on management of miscarriages, constraints on management of pregnancy emergencies, concern about legal risk. This legal concern is really huge because we've had cases of clinicians getting arrested. Not just that, there's also some states have this rule, I forget what it's called, where you could report as a citizen others who have gotten care, and you can do like a citizen's arrest. It's just ridiculous. There's so many things happening, but this legal concern is really big. Okay, so what does this mean for healthcare? I think I erased that by mistake. Oh no, it is on there. Sorry, I didn't realize I had made it like this. Let me put it all. Let me put it all in there. Okay, so in general, for healthcare and providers, legal and regulatory burdens, this is provided that for them. Clinic closures, clinics have closed in the states that don't operate. Increased costs for abortion providers, because now they're getting folks coming again from other states, and the cost shift balance has changed. Legal consequences, fear, stigmatization and harassment. This is huge for a provider as well as the user, okay, of this care. Recruitment and retention challenges, reduced training opportunities, huge impact on patient access. These are some of the things, major provisions of that. Okay, now let's look at this. Again, Kaiser Family Foundation, fabulous. They have this one piece where it compares. This was like a week before election, but in general, it was trying to show what the different parties have done. This is regarding abortion specifically. There's so many other healthcare issues. You can go in and take a look. But everyone's like, okay, well, what's going to happen? What's going to happen? Now we have this individual coming in that has had a history of certain statutes and activities in their previous presidency, but now coming in, these are some of the things. It's a little small, but basically, there are fears of the Trump administration, again, putting a national ban. That's one of the biggest fears, going back to a national ban, as opposed to having states have control. Although in the rhetoric, you know, his party is saying, no, we're going to keep it, but there's still a big fear that it's going to go back to national. Again, national ban. Using the Comstock Act. Do any of you know what that is? So the Comstock Act, it's an 1873 anti-vice law banning the mailing of articles used to produce abortion. I took that, there's an extra word in there. It was like mailing of perverse articles. It's actually written perverse articles used to produce abortion. This is an act, okay? And what the fear is that the new presidency and the new team coming in is going to actually reinstate that Comstock Act. Okay, so that way you cannot mail anything, for example, like any medication to induce abortion. It could also, and people are in fear of also even relating it to contraception and other types of things. So this is a very big thing people are worried about. Regulations blocking providing counseling, admission-issued regulations that block clinicians and providing counseling. This is actually, the last two are officially called gag rules. So the first one refers to the domestic gag rule, and then there's an international gag rule, or what they're calling the Mexico City policy. So the gag rule is basically not allowing discussion, okay, by clinicians and providers about abortion services. So this is a huge fear that that's going to get implemented again, to reinstating that. And what happens when that happens is a lot of clinics and a lot of providers actually pull out because they don't want to participate. So that actually leads to that, again, impacting access. And then there's the global gag rule, which is similar, but it's towards organizations that globally provide access to abortion and other I forget the word. Anyway, but it applies to global organizations, okay? And the U.S. puts a lot of money into global organizations and health. So that we're afraid that it's going to be also a global gag rule. But these are the major concerns moving forward. There's some other ones as well. Defunding Planned Parenthood altogether. We went back and forth. Planned Parenthood is one of the major clinics that provides not just abortion, but actually care for women's health, you know, contraception, annual visits. It's actually a clinic, charity-based clinic, you know, a clinic that provides care for low-income individuals. So just defunding that in general. Okay, so moving forward in general, what are the things we need to be worried about, and what are the things that we need to work on given these circumstances, a new political party, And who knows what else is going to happen in the future. So there's some major big ticket items. We have to, in the United States, particularly, and I could say globally too, but basically in the US, we have to address and eliminate inequalities in health coverage in general, right? And especially pertaining to abortion, because our health system is not set up to be protective. So we have to go the additional steps to actually create a protective health system. Build a delivery system and coverage policies responsive to reproductive and sexual health needs of women and other gender minorities to promote health outcomes, improved health outcomes. Develop policies to protect low-income women from experiencing financial barriers of care. Implement policies to improve maternal health outcomes and eliminate structural and systemic barriers to care, because this is ingrained with a private-public system that doesn't have any checks and balances, basically. I mean, we try, but we really don't have the true checks and balances that we need to. And also provide access to comprehensive care to pregnant individuals who live in areas with states that have bans and restrictions. These are the big things we need to be moving towards to improve health of all women, but especially in the case of abortion and reproductive rights. And I'm going to wrap it at that. I don't know how much time I took. Thank you so much.